Look at your eyelids right now. Not in a minute, right now, before you do anything else. Most people glance in the mirror and see tiredness, a little puffiness, maybe some drooping they chalk up to a rough night. I see a diagnostic panel. I see a cardiovascular report card your body has been printing every single morning for years. And in over 20 years of clinical practice, I have learned that the eyelids reveal more about what is happening inside your arteries, your lipid metabolism, and the mechanical efficiency of your heart than most panels ordered during a standard physical. That is not a metaphor. That is medicine. Your eyes are not the problem. They are the messenger. And today, I am going to teach you how to read what they are saying. Subscribe right now if you have not already. It takes 5 seconds. We are working toward 100,000 subscribers on this channel, and every single one matters. The system makes money when you stay sick, not when you get better. What I am about to tell you, no one in a clinic waiting room is going to say. And it may be the most important thing you hear this year. You have been waking up and looking in the mirror for a long time. Maybe you first noticed it a year ago, maybe 3. A small yellowish patch near the inner corner of your upper eyelid. Flat, slightly waxy, about the size of a match head. You pressed it gently. It did not hurt. You assumed it was a skin tag, a cyst, just something the body does when you reach a certain age. You left it alone. Maybe around the same time, you began noticing a faint gray-blue ring forming around the outer edge of your iris, that colored portion of the eye. A thin, translucent arc, like someone had drawn a pale circle just inside the white of your eye. Your vision seemed fine, so you filed it under eye changes and moved on. Maybe the puffiness arrived next. Not dramatic swelling, just a persistent, low-grade fullness beneath both eyes that will not respond to anything. You wake at 6:30 in the morning, and it is there. You try to sleep it off and rise again at 7, and it is still there. You cut salt for 2 weeks. Nothing changed. You tried sleeping on your back with an elevated pillow. Nothing changed. You told yourself it was allergies, or your sinuses, or the dry air in your bedroom. And then, perhaps in a photograph or in bright morning light, you noticed a visible red thread of a blood vessel in the white of your eye. Not the bloodshot red of exhaustion. A single vessel, traced clearly across the sclera, the outer white coat of the eyeball, like a fine crack in porcelain. You called it stress. You called it dryness. Nobody corrected you. Nobody connected it to anything below your neck. I see this in the eyes of hundreds of patients, and almost every one of them says the same thing. I thought it was just getting older. I thought it was nothing. Let me be direct with you. That explanation is a lie. It is a dangerous illusion, and it needs to be shattered right now. Most people over 50 believe that heart disease announces itself. They believe the chest will tighten, the arm will ache, the breath will shorten, and there will be a dramatic signal that something is critically wrong. Men say they will know when their heart is in trouble. Women say the same, and so they wait. In the meantime, they take their cholesterol medication, they attend their annual physical, and if the numbers come back somewhere near acceptable, they exhale and feel safe for another year. They were addressing a symptom they had not yet felt, while actual structural damage accumulated silently inside their arteries. Think of a water pipe buried behind a wall. The surface looks perfectly fine. The paint is intact, nothing is visible, and then one morning the whole section collapses because the corrosion had been building for a decade. Your cardiovascular system does not announce its early crisis with chest pain. It sends signals through the tissue closest to the surface. And the skin and structures around your eyes are among the most metabolically transparent regions in the entire human body. The problem is not your eyelids. The problem is what your eyelids are reflecting back to you about what is happening inside your arteries, your lipid system, and the pumping efficiency of your heart itself. Before we go further, I need to say something as a physician with over 20 years of clinical experience. There are symptoms that should send you straight to a doctor, not to a video. If your upper eyelid has drooped suddenly, meaning within hours or overnight, and it is accompanied by facial numbness, slurred speech, confusion, or any weakness on one side of your body, that is a neurological emergency. Stop this video and call emergency services immediately. If you have experienced a sudden curtain of darkness descending across one eye, that is a retinal artery occlusion, and it requires intervention within hours. If you have crushing pressure in your chest, radiating into your jaw or down your left arm, that is not a research moment. Get help now. If none of those apply to you, you can breathe. You are going to be fine. But the quality of that life is worth protecting. Here is what is happening in your body right now. And I want you to understand this not as a list of isolated symptoms, but as one connected story. 5 chapters, all written in the same language by the same system. The first sign is xanthelasma. Xanthelasma, which are soft, yellowish plaques that form on the skin of the eyelids, most often near the inner corner of the upper or lower lid, are not a cosmetic issue. They are not a dermatology problem. They are a lipid deposit. Specifically, they are collections of lipid-laden macrophages, which are immune cells that have absorbed excess low-density lipoprotein cholesterol and become stranded beneath the thin eyelid skin. And here is what that means for you. When your bloodstream carries more LDL cholesterol than your liver can efficiently process and excrete, that excess cholesterol migrates into peripheral tissue. The skin around the eyelids is thin. The lymphatic drainage in that region is slower than elsewhere in the face, and the fat deposits settle there first, like sediment at the bottom of a slow-moving river. A study published in the British Medical Journal, examining data from over 12,000 adults across a 15-year follow-up period, found that individuals with xanthelasma had a significantly elevated risk of myocardial infarction, which means heart attack, and atherosclerosis, which is the narrowing and hardening of arterial walls due to plaque buildup. That elevated risk was present even in patients whose standard cholesterol blood panels appeared within acceptable range. Write that down. Your standard lipid panel can look fine, and you can still be depositing cholesterol into your eyelid skin. That is not a contradiction. That is a measurement problem. Standard panels measure total cholesterol and LDL volume, but do not capture small, dense LDL particles, lipoprotein A or oxidized LDL, which are the forms most likely to infiltrate arterial walls and soft tissue. I want to be precise about this. The number on your lab report is not the whole picture. The second sign is arcus senilis. Arcus senilis, which is a gray or white arc or ring that forms around the outer edge of the cornea, the clear dome at the front of the eye, is a cholesterol deposit within the corneal stroma, which is the structural middle layer of the cornea itself. In people under 50, a complete arcus ring is a strong, independent predictor of hyperlipidemia, meaning abnormally elevated blood fats. In people over 50, the density and rate of growth of that arc still carry diagnostic weight. And here is the critical point. A large-scale analysis drawing on data from the Copenhagen City Heart Study, one of the longest-running cardiovascular cohort studies in Europe, confirmed that arcus senilis, in combination with at least one other periocular sign, meaning any additional sign located around the eye, significantly raised the probability of underlying atherosclerotic disease. Your cornea does not generate cholesterol independently. What you are looking at in the mirror is your circulating blood lipids depositing into avascular tissue, meaning tissue with no direct blood supply of its own, which is why it persists and does not reabsorb easily over time. But that is only half of what is happening. The second part is what most doctors never check. The third sign is persistent periorbital edema. Periorbital edema, which is chronic puffiness or fluid accumulation in the soft tissue directly beneath and around the eyes, is one of the most consistently underdiagnosed early markers of cardiac insufficiency in adults over 50. I see it constantly. The heart's function is not simply to push blood forward. It is to maintain a precise pressure balance between the arterial system, which carries oxygenated blood outward to the body, and the venous system, which returns deoxygenated blood back to the heart and lungs. When the right side of the heart begins to lose mechanical efficiency, right-sided cardiac pressure rises and venous return slows. Fluid that should be drawn back into circulation instead leaks into the interstitial space, which is the fluid-filled zone between cells. The periorbital tissue, the thin, soft region beneath the eyes, is among the first areas where that fluid accumulates because it has the lowest tissue resistance in the face. Gravity pulls it downward through the night. You wake at 6:30 and see it. It partially redistributes as the day progresses and you are upright, but it is back the next morning, and the morning after that. This is not dehydration. It is not salt intake. It is not your pillow. It is your heart telling you that its output efficiency is declining. Now, here is the most important thing I want you to hear right now. The fourth sign is in the upper eyelid itself. Ptosis, which is the clinical term for drooping of the upper eyelid beyond its natural resting position, when it develops gradually over months or years in adults over 50, can reflect a condition called Horner syndrome, which is a disruption of the sympathetic nerve pathway running from the brainstem down through the neck and chest to the eye. That nerve pathway runs in close anatomical proximity to the carotid artery, the major artery supplying blood to the brain. When atherosclerotic plaque accumulates within the carotid artery wall, when that vessel wall begins to thicken and narrow, the surrounding nerve tissue can be compressed or chemically compromised. The clinical result is a subtle but consistent unilateral droop, not a sudden stroke-level paralysis, a quiet, progressive one that appears over months and that most patients accept as a cosmetic sign of aging. Researchers at Columbia University Medical Center published findings indicating that asymmetric ptosis in adults over 50 without a prior neurological diagnosis should prompt evaluation of the carotid system. The specific test to request is carotid intima media thickness measurement, which is a non-invasive ultrasound that quantifies the degree of arterial wall thickening. Most general practitioners do not order it routinely. Request it by name at your next visit. The fifth sign is hiding in the white of your eye. The episcleral vessels, which are the fine blood vessels that run through the outermost white layer of the eye, called the sclera, should not be individually visible to the naked eye under normal conditions. When systemic blood pressure is chronically elevated, the hydrostatic pressure, meaning the outward force exerted by the blood volume itself, increases within those small vessels. They dilate. They become visible. They remain dilated even when you are fully rested because the underlying pressure is systemic, not situational. You are not seeing stress. You are seeing hypertensive vascular load expressed through the thinnest tissue in your body. Research published in the European Heart Journal has reinforced that retinal and periocular vascular changes occur earlier in the progression of hypertensive disease than any changes captured by a standard blood pressure cuff reading in a clinical setting. Your eye is registering the damage before your blood pressure number reflects it, and that is a window most clinicians are not trained to look through. And right then, the picture clicked into place for me. I want to tell you about one of my patients. I will call her Margaret. 63 years old, a retired school administrator from the Pacific Northwest. Not someone who complains easily, not someone who seeks medical attention for anything short of a real problem. She came in for an unrelated issue, a fatigue she had been attributing to the adjustment of retirement. But when I looked at her face during that first intake visit, I paused the intake conversation. There were bilateral xanthelasma deposits on both upper lids, a complete arcus ring in both eyes, and visible episcleral vascularity in the right eye. I asked her, "Margaret, has anyone ever mentioned anything about the skin at the corners of your eyes?" She paused and said, "My daughter told me to get the little yellow patches removed, but I assumed it was cosmetic." I told her, "Those are not cosmetic. Before we discuss the fatigue, I need to run a full lipid panel with particle fractionation and a carotid ultrasound." Her total cholesterol came back at 210 milligrams per deciliter, which her prior physician had described as borderline acceptable. But her small, dense LDL particle count was critically elevated, and her carotid ultrasound showed early bilateral intimal thickening, more pronounced on the right side. She had been living with preclinical cardiovascular disease for what her cardiologist estimated was 6 to 8 years. She had stopped her statin due to muscle discomfort, and no one had ever followed up. She had been walking into her bathroom mirror every morning for years, looking at the evidence, and no one had ever taught her how to read it. That is the part that never stops moving me in over 2 decades in practice. The information was always there. The body had been signaling the whole time. Here is where it gets critical, and I need you to pay close attention. There are things in your kitchen right now that are actively worsening the lipid and vascular dynamics behind every single one of those 5 signs, and they appear entirely innocent. The first is fruit juice, not soda, fruit juice, including orange juice and apple juice, which millions of adults over 50 drink every morning because they believe it is healthy. A standard glass of orange juice contains between 24 and 26 grams of fructose, a simple sugar that is processed almost entirely by the liver. The liver converts excess fructose into triglycerides through a process called de novo lipogenesis, meaning the creation of new fat from a non-fat source. Those triglycerides elevate the small, dense LDL fraction, which is the particle type most associated with xanthelasma formation and arterial plaque deposition. You believed you were being healthy. You were feeding the exact mechanism driving the signs on your eyelids. The second is low-fat dairy. When manufacturers remove fat from dairy products, they compensate for lost flavor and texture with added sugars and stabilizers. Low-fat yogurt, reduced-fat cheese, and modified milk products carry a significantly higher glycemic burden than their full-fat equivalents. That glycemic spike triggers an insulin response, and chronic elevated insulin promotes hepatic lipid synthesis, meaning your liver produces more cholesterol in direct response to the sugar load. The full-fat version, in moderate quantities, does not drive this pathway. Most people have been eating the wrong version for 20 years. The third is late evening carbohydrate loading. Consuming starchy or sweet foods after 8 in the evening, when insulin sensitivity is at its daily lowest, means the glucose from that meal has no efficient metabolic destination. Insulin rises sharply to compensate. Hepatic lipid synthesis increases during the overnight fast, and your fasting lipid panel, drawn the following morning, will sometimes appear slightly more favorable than it should, because your liver has been storing excess lipid rather than circulating it. The panel looks cleaner, the tissue damage continues. Write this down somewhere you will see it. Now let me give you something concrete. I call this the Eyelid protocol. It is the framework I walk patients through when we identify early periocular cardiovascular signs and want to begin modifying the underlying lipid and vascular environment before pharmaceutical intervention becomes necessary. Part 1. Morning activation. Within the first 30 minutes of waking, drink 16 ounces of water at room temperature, not cold. Cold water temporarily slows gastric motility and delays the early morning lymphatic clearance that helps move periorbital fluid back into systemic circulation. This is the window when your lymphatic system is preparing to clear overnight fluid accumulation, and you want to support that process, not obstruct it. Stir in the fresh squeezed juice of half a lemon. The citric acid and potassium in fresh lemon juice support hepatic bile production, and bile is the primary vehicle through which the liver excretes excess cholesterol from the body. Packaged lemon juice contains preservatives that blunt this effect. This takes 90 seconds. Do it before coffee. Part 2. The midday omega load. Consume 1 tablespoon of ground flaxseed with your midday meal. Stir it into any food, any sauce, any grain. Ground flaxseed is one of the most bioavailable plant sources of alpha-linolenic acid, which is the omega-3 fatty acid precursor that reduces serum triglycerides by downregulating the liver's VLDL production. VLDL, or very low-density lipoprotein, is the precursor particle that is converted downstream into the small, dense LDL fraction most associated with xanthelasma and arterial wall infiltration. Ground flaxseed costs less than $3 per month at standard retail. This is not a supplement. This is food acting as medicine, and that distinction matters to me. Part 3. Evening elevation. Elevate the head of your bed by 3 to 4 inches before sleep. periorbital fluid accumulates nocturnally because the horizontal position equalizes fluid pressure across the face, and gravity cannot assist lymphatic drainage. A slight head elevation, even 2 to 3 inches, maintains a gentle gravitational gradient that allows the lymphatic system to continue draining during sleep. You do not need a specialized therapeutic pillow. Fold an extra standard pillow and place it beneath your existing one. This takes 5 seconds. In patients where cardiac function is in early-stage compromise rather than advanced failure, visible reduction in morning periorbital puffiness typically begins within 3 to 5 days. Part 4. The walk window. Walk for 20 minutes between 9 in the morning and noon, not in the evening. Morning ambulation improves insulin sensitivity for the following 14 to 16 hours, which directly reduces the hepatic lipid synthesis that drives LDL particle overproduction throughout the day. Evening exercise elevates cortisol at the precise moment the body is preparing to reduce it, which can impair the overnight lipid clearance process. The window matters significantly. The intensity does not. A comfortable conversation pace walk is physiologically sufficient. Part 5. The tests to request. At your next physician visit, do not accept a standard lipid panel alone. Request an apolipoprotein B level, which is a measure of total LDL particle count rather than LDL volume, and request a lipoprotein A measurement, written as LPA, which is a genetically determined lipid particle that standard panels never include, and which is among the strongest independent predictors of early atherosclerosis currently identified in cardiovascular research. Write both names on a piece of paper before you walk into that office. You are entitled to that level of evaluation. There is no reason to accept less. Margaret followed all 5 steps. She eliminated the orange juice, added the flaxseed at lunch, began morning walks, and elevated her pillow stack. 1 month later, she came back and said quietly, almost not believing herself, that the puffiness under her eyes had reduced more than at any point in the past 2 years. After 3 months, a repeat lipid particle analysis showed a meaningful reduction in her small, dense LDL fraction. The xanthelasma deposits require longer to resolve, and in some cases require clinical intervention, but they stopped progressing. Her cardiologist was satisfied enough to defer the pharmaceutical conversation to a 6-month evaluation window. That is not a miracle. That is physiology working correctly when you give it the right inputs. How old are you? Write it in the comments right now. I want to see which age group makes up the majority of our viewers, because it will directly shape what I cover in future videos. Whether you are 52 or 67 or 71, your number matters to me. Here is exactly what to do after watching this. Step 1. Look at your eyelids today in natural daylight, not a bathroom mirror under artificial light. Look specifically for yellow patches near the inner corners, a gray ring around the iris, persistent under-eye puffiness that does not resolve with sleep, visible red vessels in the white of the eye, and any asymmetry in the upper lid position between your 2 eyes. Step 2. Request an apolipoprotein B and a lipoprotein A test from your physician at your next visit, and write those names down before you go in. Step 3. Remove fruit juice and late evening starches from your diet this week. Not eventually, this week. Step 4. Begin the morning water and lemon routine tomorrow. Step 5. If you experience any sudden eyelid droop, sudden one-eye vision change, or chest pressure, stop and seek emergency care immediately. Those are not questions for a video. Your doctor is not going to walk you through this at your next appointment. There is no revenue in it, and there is no time on a 12-minute office visit to explain the relationship between xanthelasma and small, dense LDL particle infiltration into the arterial wall. I am Dr. Candace Miller, and I have spent over 20 years watching what happens when people treat cardiovascular risk as a future problem. Most of the time, the damage was entirely preventable. The protocol I just described requires no prescription, no procedure, no money beyond a bag of ground flaxseed and a lemon. It requires only the understanding of how your body actually works and the discipline to use that knowledge every single morning when you look in that mirror. Subscribe to this channel hit the like button and help us reach 100,000 subscribers. Every person who subscribes makes it more likely that the next person who genuinely needs this information will actually find it. This video is for educational purposes only and does not constitute medical advice. Always consult a qualified healthcare provider before making any changes to your health routine.